define what COX2 inhibitors are, let us first differentiate COX1 and COX2, which are the enzymes being targeted by these NSAID medications. So first, COX1 produces prostaglandins that activate platelets and protect the stomach and intestinal lining. However, COX2 are only responsible or only active at the site of inflammation. Now, most NSAIDs target both of these enzymes that sometimes may cause to gastrointestinal bleeding, gastrointestinal erosions, or erosive gastritis, in which parts of the stomach and intestinal lining wear away because these NSAIDs suppress COX1. Now, these gastrointestinal erosions can be uncomfortable and may lead to dangerous problems like what I said before, gastrointestinal bleeding. So if you're at risk for gastrointestinal problems, or if you already have one, COX2 inhibitors or selective COX2 inhibitors may be safer for you than regularly using non-selective NSAID medications. Now, these selective COX2 inhibitors are often given for inflammatory pain such as that from osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis. In addition, COX2 inhibitors are also recommended if you have a history of gastrointestinal bleeding or if you're on an anticoagulant medication also called as blood thinners.
The pharmaceutical phase of a COX2 inhibitor, an example of which is Selecosib. It is a small molecule type, approved and investigational. Selecosib is a selective cyclooxygenase 2 or COX2 inhibitor, a non-steroidal anti-inflammatory drug which is known for its decreased risk of causing gastrointestinal bleeding compared to other NSAIDs. It works by stopping the prostaglandins production. Prostaglandins are substances which cause pain and inflammation in the body. It is marketed by Pfizer under the brand name Celebrex and was initially granted FDA approval in 1998. Its average weight is 381.372 and for monoisotopic is 381.075882012. A chemical formula of C17H14F3N3O2S and with a given IUPAC name. The effective half-life of Selecosib is approximately 11 hours when a single 200 mg dose is given to healthy subjects. The terminal half-life of Selecosib varies because of its low solubility, which prolongs absorption. Selecosib is available in two forms, tablet and capsule. The strength of this drug is available within given stocks: 50 mg, 100 mg, 200 mg, and 400 mg. Moreover, this drug should be taken orally with food to reduce GI upset.
After oral administration, celecoxib is rapidly absorbed and achieves peak serum concentration in about 3 hours. It is extensively metabolized in the liver with very little drug, less than 3% is being eliminated unchanged. The major routes of excretion for celecoxib are feces and urine. Celecoxib is metabolized primarily through methyl hydroxylation to form hydroxycelecoxib. This reaction is largely catalyzed by CYP2C9. Hydroxycelecoxib is further oxidized to form carboxycelecoxib via systolic alcohol dehydrogenases ADH1 and ADH2, then conjugated with glucuronic acid via UDP glucuronylyl transferases, also known as UGTs, to form the 1,O-glucuronide. None of the metabolites are pharmacologically active since celecoxib metabolism is predominantly mediated via CYP2C9. Polymorphins in CYP2C9 are likely to have a direct impact on celecoxib pharmacokinetics and variability in drug responses. Individuals who are poor metabolizers of CYP2C9 substrates have increased exposure to celecoxib when compared to those with normal CYP2C9 activity. Drugs that inhibit CYP2C9 should therefore be used with caution in patients taking celecoxib. Although not a substrate of CYP2D6, celecoxib inhibits this metabolic enzyme. Drugs that are metabolized by CYP2D6, for example metoprolol, should also be used in caution with patients receiving celecoxib due to a potential risk of drug interaction.
Celecoxib is a non-steroidal anti-inflammatory drug, or NSAID, that selectively binds and inhibits cyclooxygenase 2 or COX2 over COX1. This prevents the conversion of arachidonic acid into the pro-inflammatory prostaglandin, leading to a reduction in pain, fever, and inflammation.
Peptides work by reducing the production of prostaglandins, chemicals that promote inflammation, pain, and fever. Prostaglandins protects the lining of the stomach and intestines from the damaging effects of acid, promote blood clotting by activating platelets, and also affect kidney function. There are types of COX enzymes, which are COX1 and COX2. COX2 enzymes reduce prostaglandins that promote inflammation, pain, and fever. However, only COX1 produces prostaglandins that activate platelets and protect the stomach and intestinal lining. NSAIDs block the COX enzymes and reduce production of prostaglandins. Therefore, inflammation, pain, and fever are reduced by all COX inhibitors. Since the prostaglandins that protect the stomach and promote blood clotting are also reduced, NSAIDs can cause ulcers in the stomach and intestines and increase the risk of bleeding. COX-2 inhibitors only block the COX-2 enzyme. Since COX-2 inhibitors do not block COX-1, which primarily produce prostaglandins that protect the stomach and promote blood clotting. They do not cause ulcers or increase the risk of bleeding as much as the older NSAIDs. Nevertheless, COX-2 inhibitors are as effective as the older NSAIDs for treating inflammation, pain, and fever.
So guys, I am now back home and I'm here to talk about the route of administration of COX2 inhibitors. As mentioned, COX2 inhibitors are a type of non-steroidal anti-inflammatory medication or NSAIDs which selectively block the COX2 enzyme. According to an article by MedicineNet, most of the COX2 inhibitors are orally administered. In addition, patients having COX inhibitors as their medication should know that taking it with aspirin or other NSAIDs may increase the risk of stomach and intestinal ulcers.
COX2 inhibitor side effects include insomnia, abdominal pain, flatulence, headache, nausea, diarrhea, pharyngitis, rhinitis, sinusitis, peripheral edema, accidental injury, dizziness, upper respiratory tract infection, rash, indigestion, and diarrhea. For nursing considerations, assess range of motion, degree of swelling, and pain in affected joints before and periodically throughout the therapy. Assess patient for allergy to sulfonamides, aspirin, or NSAIDs. For patients with these allergies should not receive celecoxib. Assess patient for skin rash frequently during therapy. Instruct patient to take celecoxib exactly as directed. Advise patient to notify healthcare professional promptly if signs or symptoms of GI toxicity, skin rash, unexplained weight gain, edema, or chest pain occurs. Advise patient to notify healthcare professional if pregnancy is planned or suspected.